Hello, everyone. Welcome. As you're getting settled, we'll be starting in just a few moments. So please grab a beverage, a snack, and we're looking forward to having this digging deeper session with our wonderful and esteemed colleagues, Linda Coleman and Madelon Baranoski from Yale. Just letting folks get settled. Perfect. Well, welcome everybody. Good morning, good afternoon, good evening, wherever you may be in the world. Welcome to the MRCT Center's Return of Individual Research Results and Data, Digging Deeper three-part summer series. Today, we're focused on the second of our three-part series on IRB and HRP responsibilities within the context of returning individual results and data to participants. And as I mentioned as you were coming in, we're joined today by our wonderful esteemed colleagues, Linda Coleman, Director of the Yale Human Research Protection Program, and Madelon Baranoski, who is a forensic psychologist and also an IRB chair at Yale University. And they'll be talking a little bit about this experience they had with returning individual results within the context of the coronavirus pandemic and them being non-validated findings. But before I get into all of the details with them and with the session, I'm going to go through a few little housekeeping items. So one of the things is you might be noticing you're coming into this meeting, and it's a meeting. It's not a webinar where you can't see everybody else. So regardless of whether you're on camera or off camera, what you are able to do is kind of scroll through all of the participants. Right now, we've got 103, and it looks like it keeps ticking up because it was really within this digging deeper spirit that we wanted to convey that you're part of a community of people that are working on this issue. Maybe sometimes it feels like alone, but you're not. We're all in a community of people who care about this participant desire and need to receive individual results and data. And so I wanted to create that kind of environment that feels a little less anonymous than a webinar sometimes can feel. Now, you noticed probably also that you came in muted, so please do keep yourself muted throughout the course of the webinar and meeting, just so that we're not having any interruptions or noisy distractions. But please do feel free to use the Q&A function to submit your questions. That is the goal. After Linda goes through an overview of the case study again and just gives you some high-level details around what was done at Yale and how it was handled, then we're going to move into the discussion. We have some questions prepared, and we're ready to take questions from you, the participants who are here today. Closed captioning is also available. So at the bottom of the screen, you can activate closed captioning under the dots on under more at the bottom there. And then we just ask that you leave it in English, because if you do activate closed captioning and choose another language, it garbles up the closed captioning because it's using AI to recognize the language that's being spoken to do the closed captioning. So it's linking to our spoken language of English. So please leave it as English. And then lastly, I know I jumped ahead there will be a recording that's available within a few days of this session. So don't worry about that either. You'll have this to reference. You'll be able to share it with your colleagues. And for folks who have registered and couldn't come, they'll be able to see this and get this information as well. So that will go into an email to you when it's ready and will be available on our website. So before we get started, I also need to make a note of the regular disclaimers of the MRCT Center, that these are our opinions and not necessarily representing the position of Brigham and Women's Hospital, Harvard University, or any other organization, government, or entity. We at the MRCT Center are funded by voluntary contributions from a variety of different sources, but regardless of where we get our funding, We remain completely committed to the autonomy in our research and transparency in our relationships. And so it is the MRCT Center and the leadership there that retains responsibility and control of all the content of any product's results and deliverables. And there are no personal financial conflicts of interest to disclose today. For those of you who aren't familiar with the MRCT Center, we are a research and policy center based out of Boston and Cambridge, Massachusetts. Our vision over the last approximately 15 years has been to improve the integrity, safety, and rigor of global clinical trials. And we have been doing this work by engaging diverse stakeholders from across the research ecosystem to define the emerging issues and also, I guess, the continuing issues, the pain points that keep on tripping people up in the global clinical trial space, and then trying to create and implement ethical, actionable, and practical solutions. And this emphasis on practical solutions is really key because as you'll hear today in this conversation about this case study, right, this is about practical experience on the ground and the way that people in real life are dealing with some of the complexities that come up when returning individual results and data to participants, and really is a testament to this effort of transparency that we want to promote in the clinical research environment. So in terms of the individual return of results project, if you'll recall from our webinar in May, when we originally launched the case studies, you may remember that we actually had work in the individual research results space going on back in the 2013 to 2017 time. There was a toolkit that was released back then. In sort of, as is customary for the MRCT Center, we do revisit the work that we do to make sure it's up to date, that anything that we need to update gets updated. And so in January 2021, we had a task force established to create updated operational and implementation-oriented tools around individual research result return. And then we released a new website with that information in March of 2022. And it was then, a year later, approximately, that we launched these case studies. And there's a series of case studies that were discussed at the May 2nd launch of those case study exercises. And then also now we're doing these digging deeper because there was so much enthusiasm and excitement about the case studies that we've had a few of these. We're planning a few of these discussions. And so Kristen will be placing some links into the chat that link to the May 2nd webinar. So you can go back and find that information and so that you'll be able to use that in the future. And so just as a quick overview of the website itself, we really put a lot of effort into trying to create a resource that allows people to really think through the various steps involved in returning individual results. So we have the sort of classic how to use the website, how to get started, why to get started in returning individual results, and giving you some of the background justification that may be needed with your leadership or in your organizations to get this work moving or keep it moving. Then we get into some of the more practical stakeholder resources like roadmaps. Are you the IRB? Are you an investigator? Are you a sponsor? Are you a participant? There are different stakeholder roadmaps to think about the various issues that may come up in returning or, in the case of a participant, receiving results. So you can use those roadmaps to guide your process in planning. There's determining what to return, how to return, the who, when, how, etc., and as well as result-specific guidance. And we also have tools and templates available under resources, additional resources for participants. And if you want to go back and see the 2017 resource, the guidance and toolkit that was released back then, that's available there too, as well as the case studies. So as I noted, there's been 5 of those that were released this past spring. And we're going to be focused on this purple one, returning non-validated tested results today. But before, again, we get into that, just a reminder, you can register for September's session now. Kristen will put that link into the chat as well. So that's there for you. And I want to especially thank all the authors, all the task force members, and the case study authors. You can see those in images here, in addition, of course, to Linda, who drafted this case today that we're going to be discussing. So without further ado, let me just pass the baton on to Linda Coleman. Thank you so much, Linda, for joining us today. And I really look forward to hearing your overview of this case, and then we can have the discussion, the promised discussion. Great. Thank you so much.
Well, thank you for the introduction, and thank you all for joining today. I recognize a few faces and names. There's many of you on the call today. So what I'm going to just do is just kind of provide a brief overview of the case itself and kind of, some of the issues that we grappled with. As Sylvia mentioned, this particular case describes how our Yale IRB and our HRPP sort of grappled with this particular study that was submitted to our office during the COVID-19 pandemic. I know we're still kind of dealing with some of that right now, but this was really in 2020 at the very kind of the beginning of the pandemic. And so for some of you may have already reviewed the case, but I'm just going to walk through, so I think some of the details and facts are important here. So in this case, this investigator was, creating a repository for current and future research involving the epidemiology and pathogenesis of emerging viral infections. So it's very timely, and it included the coronavirus. And one of the aims really focused on validating this university developed assay to test for COVID-19. So one of the things I would want to mention here is this test was being developed in a non-CLIA certified lab. Now, I'm not sure how many of you are familiar with CLIA, but I'll just kind of describe it kind of at a higher level. And so what CLIA is the Clinical Laboratory Improvements Amendments of 1988, which is called CLIA, is intended to ensure that the laboratory results used in patient care are accurate. And the center's CMS is one of 3 federal agencies that are responsible for administering the regulatory standards under CLIA, and is responsible for compliance inspections. And one thing that is important here is CMS has a very, very narrow interpretation, and it basically states that CLIA prohibits the return of individual research results, that would be the case here, to a study participant from a laboratory that is not CLIA certified and considers any return of research results to participants to be considered diagnosis, prevention, or treatment purposes. Okay, so they just say that. And they say that even if you accompany it with with a disclosure that the samples shouldn't be used for clinical purposes. So one of the things that some institutions have done or have grappled with is, well, why can't you just say that we're going to go ahead and return this research result and just say in the consent form, or tell a participant that you shouldn't be using this for clinical purposes. We're just giving this to you for whatever reason, right? But CMS has interpreted this as being not allowed. So it makes it kind of difficult. Now, one other factor that's important here, and I'm going to talk about this next detail in the case, is that in this particular case, the samples that were going to be collected in this particular study or this research were from hospital inpatients and outpatients. So now we also have the issue of being a HIPAA covered entity issue as well. And under HIPAA, if you obtain, basically individuals have a legal right to request and obtain test results from a HIPAA covered laboratory when such results are part of a designated record set. So the issue here also is, so not only is a disclaimer an issue, but if you go ahead and you put this information in a record set, like you put it in your Epic or whatever, your electronic health, a medical record, that kind of a thing, that could be problematic as well, because now as a patient, you have a right to receive that information. So again, there's a lot more details there I could probably get into. If you're interested, SACHARP did a really nice kind of summary of some of the laws, some of the issues with HIPAA and CLIA, and even FDA, if you might take a look at that. And I know that there's some other references as well. So going back to the case, so in this particular case, again, we're collecting samples from inpatients and outpatients. They're either suspected of exposure to COVID-19 or they're having symptoms of this infection. And so basically what happened here was the samples were first tested in this non-CLIA certified laboratory using this university developed assay, which is part of the research here. And then a decision was made that all of those samples would need to be retested in a CLIA certified lab to validate the results. So in this particular case, the IRB grappled with, well, in light of the public health emergency, what is our duty to return these results? If the results that are returned result in potentially a positive result, what is our duty to return them? And so in this case, the IRB weighed this risk and determined that in light of this public health emergency, that they had an ethical obligation to, at a minimum, return provide information to the provider, not directly to the participants, but they wouldn't actually return the results themselves physically or put them in Epic or anything like that. They would just tell the provider, and then they also would immediately on their own send that same sample to a CLIA certified lab, and then they would return the CLIA certified laboratory results to the provider. So it's a little bit different. Trying to be compliant with the regulation, but at the same time address the issue with the public health emergency. So again, just to sort of summarize here, what happened was the decision was made to have a phone call with the provider, letting him know about this potential unconfirmed finding, letting him know that the samples were being sent to a CLIA certified lab for verification or confirmation. And then once those results came back, then they would be returned to the provider directly. And then of course, there are also these mandatory reporting requirements as well that needed to take place as well. And those were also addressed. Now, another piece of this, there were some requirements, and in the case study, I'll let you read that on your own, that kind of talked about how much time had to elapse from the time that the research test was done versus when the CLIA, the time that it was sent to the CLIA lab and the return, and how quickly it had to be returned. And some of those details are in the case study as well. And so in terms of the decisions again, and then we can turn it over to questions. We kind of looked at the regulatory requirements and the conflict between HIPAA, CLIA, and some of those issues, and how can we address it in light of the public health emergency, and in light of the fact there was no guidance provided that we were aware of anyway, regarding if there was any sort of exception. And we also looked at this concept of harm reduction. Again, there's a nice paragraph in the case study that kind of speaks to the issue of, you know, balancing the fact that we're in the middle of a pandemic, and in light of the fact that yes, it will cause some kind of psychological distress, just potential disruption of work, etc. If your provider tells you that maybe you should take some precautionary measures, even though it's not confirmed. So there's lots of those issues that we talked about as well. And then we also just want to look at the scientific integrity of the research. We wanted to make sure that this test was being, validated as well, because that was the whole point of the research. There was, in the case study as well, we did provide some very specific language in terms of what was communicated to participants, really reiterating what was going to be happening if there was an unconfirmed finding, and also some specific guidance to providers as well. And I will say that it just might seem all very simple, but at the time it was not very simple. There's a lot of conversation with Madelon Baranoski, our IRB chair. I was involved, and also in getting into the details about, do we do an email? What happens if you do an email? Should we do a phone call? How do you verify that? What happens if you can't get a hold of the provider? What do you do? So there's a lot of conversation about some of those operational details that were really, really important. And then finally, I would say that we also had to address the inpatient versus outpatient situation, because the inpatient has certain ramifications, implications, and then the outpatient setting as well. So again, looking at how do we communicate this information so that we can ensure that this information is being provided in a timely manner. So that's really just a really high level overview. I think that many organizations even outside of the pandemic context, do struggle with this issue, and the regulations unfortunately have not really addressed some of these issues, especially in a situation where you have this research being done in a covered entity, and that sort of thing. So again, I will stop there, and then we can turn it over to questions. Or Madeline, if there's something else you wanted to add that I didn't cover, please do so.
Linda, I think you covered it very well. I want to tell you two issues that the IRB struggled with because this test was still under development, and the sensitivity and specificity, that is the rate of false positives or false negatives, really had not yet been established. That's what they were establishing, even though the test was based on very good animal models. So the likelihood that it had good pharmacokinetic properties was probably there. It still wasn't established. And so we were very careful to be certain that all samples had to be tested, not just the ones that pinged positive, because those that pinged negative still could have been the false negatives. Mm-hmm. And the other consideration, as Linda mentioned in harm reduction, often you return tests in a timely manner because the person can be affected, and starting care as soon as possible might be important. In this case, it was not only treatment, and actually at that point we had no treatment, but rather to prevent the spread of the virus. And so to consider the impact of spreading the virus was what influenced the IRB to insist that we find a way to release the results.
Mm-hmm. And I think that's what I found like kind of so amazing about this, because I worked at the BU IRB for many years, and we used to talk about this idea of non-validated findings, non-CLIA certified findings, and just not being able to return them, and yet trying to find a method within the context of a public health emergency to be able to return this information was kind of, I mean, we said unprecedented a lot back then, but it really was for the context of research and returning research results. And a circumstance that hadn't necessarily been dealt with at that scale before. And I love, I mean, maybe we can just start with a little bit of a conversation, just like the phone call, right? Because that was sort of an additional logistical piece that you added in. So why, you kind of answered why the phone call, but like now moving forward, like other methods that can be used, you know, email, EHR, what does the Yale IRB kind of look for when people are talking about returning results, and what that could be like in terms of returning important findings to investigators, to providers?
Well, one of the things the IRB considered, and this was with a lot of Linda's input and back and forth, was that a phone call would offer the advantage of an exchange of information between the PI or the PI's delegate about what the test was about, what it could show, what next steps would be important, about the CLIA validation that was going to occur, and to guide the receiver of that information. In addition, the PI is an expert in communicable diseases. So that communication could say, so what do I tell my patient? There was help there. We worried about emails because at the time, the level of communication often was passed on, and we were concerned about putting it in the electronic medical record because it wasn't validated. Mm-hmm. And could it be misread or misacted on? So it was an extra step. We did get some pushback about the demand this would require, but we felt it was the only way that we could balance the risk benefit of returning the results.
Mm-hmm. Mm-hmm. Linda, did you want to add anything to that? No,
I think really, I mean, really the whole, and I was concerned about the regulatory issues of the using email, and then also the EHR and what that implications were. And we didn't have a lot of time to sort of research and talk to other institutions about, well, how have you handled this? And I also think that in terms of the timeliness, the telephone call was probably the most effective to what Madeline was saying in terms of given what was happening, because with email, things get lost, or and in putting it in a record, it may be misinterpreted, and even separate from the regulatory issues that we would have to face with that.
And did you have some sort of a documentation process that you expected then from the research team to have documented when that conversation happened and when that handoff of information occurred?
Yes. So we actually, it's not in the case study itself, we didn't include that. We actually had an entire, I mean, Madeline and I went back and forth, but even somewhat of a script that should be used to how to communicate the information. Of course, there's some ability to kind of go outside the script, but we had a script, and it was very, very specific in terms of when it had to happen. It had to be done within a certain time frame, and there had to be documentation, in the research records of, those communications, that sort of thing as well, so that we could document that it actually occurred. And if there was, and I think at this point, I don't think, Madeline, we heard any sort of issues with our investigator having difficulty getting in touch with the provider. I think that because, especially on the inpatient unit, it's pretty easy to do, and even on the outpatient. So I think they did a pretty good job of following some of the operational requirements that were imposed by the IRB. And this was actually reviewed by the IRB in terms of very, very specifically how that should be done.
We actually got positive feedback about this working very well.
Oh, great.
And the PI, who was very concerned about not giving the results back and doing it in the right way, was very appreciative of this method laid out this way.
And I think one thing, we didn't actually get to talk about this in our preparatory conversations, but I do think about the sort of the fact that you were able to have a study that was, it seems like it was self-contained in the sense that you would be able to reach out to providers, but other studies that are larger, that are maybe multinational or might have many different sites, there may be some challenges with that sort of expectation around phoning or sort of that handoff, that soft touch of information. Do you have any thoughts on that, or reflections of sort of how that could scale? This sort of a model might be able to scale into larger studies, and also taking into account some folks might not have a provider that you can reach out to. Have you thought about those things and considered that in the past?
I think one thing is that's where local context comes in. And appreciating that one system may work in a different system. I'll give you an example from this case study. So the CLIA lab had agreed to do the validation, but for the research. But the IRB said, no, we want it fast, because they were going to store the samples and get to it, because that validation was actually going to be used to establish the sensitivity specificity. With another test that was validated and FDA approved. And when the CLIA lab heard that, no, we want them done now, they were being overwhelmed because so much testing was going on that the question of who would pay for it came up. And because Connecticut at that time had public health monies, and so did a number of other states that came under the COVID money. But remember, it was very early before a lot of the support had gone out. The state of Connecticut was paying for validation of the test. So it wasn't going to the patient or the subject, which was an issue that came up. We were able to resolve that, but if we didn't have those funds, where would the cost have gone? That would have been a problem we would have had to see.
Makes a lot of sense. And really, those logistical issues and very like local context and situation specific, right? I mean, around the circumstances that allowed the testing to be able to happen in a validated setting then as well to confirm. Well, let me take a question from the audience. There's one here that's that Kathy Baranoski shared. And so she wrote, was the goal of the research to develop a laboratory developed test, an LDT? And if so, how did FDA's emergency use authorization provisions for diagnostic tests during the public health emergency play into your decisions, or did it? Was that something that even came up?
It was
be
too
honest,
early.
Yeah, it was really early in the process, and at that point, it did not come up. It was really more focused on kind of what we described about the CLIA HIPAA issues. We did not get into that at that time.
Yeah, might happen now, or might happen for other types of research now.
Definitely.
Well, when we were talking about all of this, when we were developing this case and sort of in our conversations before today, we did talk about other scenarios, right, where we're considering return of non-CLIA information to participants or healthcare providers. So, and there are ones we can think about. Maybe I think we came up with a bunch of examples, right? A research essay for TB. We talked about a gout example, colchicine for gout. You might want to talk about that example, Madeline. But what lessons have you learned from the pandemic and conducting research during a pandemic that still apply today, that you've carried into today as you consider other research that may have unvalidated findings or may want to be sharing back to participants?
I'm going to talk more about the operational piece and let Madeline speak to the other point here. I think what's really important here that we learned just generally is the importance of really a lot of communication between an investigator doing a researcher and the treatment teams, because if you're doing research with inpatients, making sure that your treatment teams are aware the research is occurring. I think it's really important. So there's a communication, and again, it provides an additional level of support for the research as well. And even on the outpatient setting as well. I think that was something that I know a lot of organizations probably have mechanisms in place that require such communication. But when you're in a chaotic state like a pandemic, everybody is wanting to do a lot of really, really good things, right? We actually even had like social behavioral researchers wanting to do research, in the clinical space. And so trying to navigate all that. So from my perspective, it was really, I think in terms of, the issue of CLIA and HIPAA and what you can return and not return, we kind of have a policy that we pretty much comply with. And then we always have to balance that with the ethical piece about what the rights that what we should we return. I mean, in this case, the fact that we were under a public health emergency and the potential infection and other issues here sort of outweighed some of that, and making sure that we did return this information to the provider. But again, in any type of research, I think, making sure you have a clear plan in place. And I think sometimes like investigators lose sight of that. They're focusing so much on the science and not the how-to part. And I think that's what we learned, at least we did, the importance of that and that partnership with the IRB and the investigator and trying to help them navigate that if they have not thought of that already.
What was clear in the emergency was the risk benefit of getting it out to try to prevent further spread of the virus in people who were infected and might not know that, and this test might have identified it. I think the issues that come up in other non-pandemic like situations are very complicated. And I found the principles out of the toolbox very, very helpful. And I'll give an example. Often the PIs with incredibly good intentions identify that results will be returned without necessarily understanding exactly what the process is at the point of the test and the interpretation. And one set of studies that have this are when MRIs are being done for research, particularly fMRIs in many psychiatric, psychological studies, they're being done. The what the technician reads at the end of the MRI is whether it's a readable MRI. And a number of them are not able to pick up abnormalities, but some will. And so to say, if we see anything in the consent form, if we see anything, we will let you and your doctor know. It implies that every scan will be looked at to see if you see anything. but unless that's happening, that is incorrect information being given out. And so then the IRB, I think, has to step back and say, are we going to require a read of every scan for abnormalities? If not, we can't imply that we are, and rather let a one-off come up as they come up, where there's a very experienced clinician who can pick up something, or not clinician, but just technician who can pick up something that others can't. And we've had examples of that. So I think it needs to be a very principled and careful examination of what we mean by returning results when, how soon after the test is done, and how certain we are about negative findings.
Yeah, so I remember when we were talking about the MRI situation, and this idea being that, you know, if we're not going to be able to give some meaningful information to people, it makes me think about the language in the consent form. I think that's where I'm trying to go here. Like, when the implication being that someone's going to look at it, well, maybe would it be better if we said, like, this isn't being done for clinical purposes, no one will look at it, but if someone does see something, right? Like, I think there is some couching that might have to happen as well when we think about the way that we frame things within the consent form, so that people are aware of what they're getting or not getting in the context of the study. And actually kind of tying a little bit to that, Jim Feldman, who's one of the chairs at the BU MC IRB, has a question here about whether Yale has revised its written policies and lawyers approved a revision when non-CLIA certified research results can be returned to participants or providers. The public health emergency was an unusual case. Yes.
The answer to the question is the policy, or I should say the policy or practice, has not changed at all. I think that they are very, conservative. And I did look at some other ones. We do periodically look at what other institutions are doing, and they're all very similar, where they pretty much follow this fairly strictly. I know originally we did have some language many years ago, Madelon, you might remember this, where there was an exception built in. So there was an exception built in, but then when we revisited it again, there was some concern about returning this information at all, like we actually returning an actual result. I think in the situation that we just described, we actually didn't return a result. We had a conversation that said we have an unconfirmed finding. That's a little different than saying, here is your MRI, or here is the actual result, and now you need to, this is not for clinical purposes. There's not, we don't do a disclaimer. Again, we have a policy where we don't add a disclaimer at all. We don't allow for that at all. It has to be, we have to, if we're going to return information, it would have to be directly to a provider. That's typically how we handle it. Now, I will say that doesn't cover every scenario, because as you mentioned, not everyone has a provider. So what do you do under those circumstances? So again, we have not finished having this conversation here at Yale, so don't have an answer to that question.
Well, and I think sort of just following the breadcrumbs on policies or things like, what's your position, the Yale IRB position on including information on individual return of results in the informed consent form? I think we talked about that unique circumstance of MRIs and like whether it'll be read or not. And I see there's a question also about that, so I'll come back to that as well. But do you expect any information being put into the consent form, and whether researchers have to obtain consent to return results?
So Madelon, you see some of these. So.
Yes. So a number of our consent forms will say the results will not be returned. And then we have to go and say, well, are any of them being done by the lab at Yale New Haven? And they automatically are going into your record. So what do we mean by no results will be returned? And why? But then the next question is, what's important about that? How specific do we need to be in the consent form. So what we generally say is any of the tests that are considered standard of care tests will be included in your a medical record, and those will be available to see. Those that are being done for research only will be part of a research record and will not be returned. But if you have questions, please ask. And that part about engaging in a conversation, I often think we say over and over again, the consenting process is not limited to the form. And to remind, I think we're reminding the team that conversation should happen, that the research tests often are duplicative. They're about a drug rather than about the person. I'm thinking about the pharmacokinetics, or they're not established yet as valid tests. So that's why not returning them isn't really withholding something about your health, if that's true.
Mm-hmm. And that's, again, yes, those conversations of putting that into descriptions of the study, some reading about the study in terms of what we're expecting to learn from that study. Because like you say, like a PK study or something like that is not going to necessarily have meaningful information for a person, but that they understand that, and that's
right.
That not only are results not going to be returned, but they're not really interesting or applicable to your health. You wouldn't make any health decisions based on that or anything. And so I think it really requires to think a little bit about the way, the sort of even the boilerplate language that we kind of use, that we agree upon perhaps, but then find that in the nuance of these kinds of conversations may be inadequate or may not be entirely helpful or meaningful to people. So it does raise some questions about how we think about our consent forms again and more. Well, and tying to the consent form, I mean, what kind of information are you expecting to see in the protocol around individual return of results? Do you, first of all, within your application system, already have a question that asks about returning data and results and sort of asking people to walk through, and do you pick up on some of that nuance if they say, no, we're not returning results, but it's standard of care testing that is going to go into the record or whatever? Do you pick up on some of those things and call the investigators out on it?
We do ask. I mean, so all of these tests are being done. They're patients at the time they're subjects, if they're being treated inpatient or outpatient, it doesn't matter. And that's going to be part of the medical record. So to say none of this is going in is not accurate. Mm-hmm. And we'll ask, can you identify what will be separate? Again, I think the clearest one is around the pharmacokinetics, where you can say what the drug manufacturer really wants to know is how the levels of the drug vary in different people over time. And for any individual, it really doesn't mean anything. It's just when they put it all together, they're really learning something about the drug.
Yeah.
And whether that detail has to go in the consent when the consent is already too long to begin with, but that's the conversation.
Right. That's right. That's right. Well, and so kind of going back to this idea of the MRI, I think that people love to talk about those examples because it's such a classic one. Many of us were in fMRI studies, maybe in college, to get that $25. So why, there's this question then, like, why do a test if it's not read and interpreted properly? And, to some extent, it seems like that is the exact point of returning the results, right? Is that someone be able to take action on that. But I think we're talking here about these more traditional social behavioral psychological studies where fMRIs are done not for diagnostic purposes, not for clinical purposes, and they're perhaps observing something in terms of activity in the brain or things like that, but that's why they're not necessarily designed to be read and interpreted per se for clinical purposes. But maybe Madeline, you can help me out since I'm not the MD in the
Well,
room.
I'll give you, and this raises an important ethical issue for me. So many of these studies are done on healthy controls. So I think of a lot of in the neuroscience right now, occupancy that's determined on different parts of the brain by radio tracers and so on. And every subject, before they have the PET scan and so on, has an MRI first to identify which part of the brain are we looking at and so on. At Yale, and I think at other places, those MRIs are done for research only, and they're not done in the hospital system. There's a separate place that does them. So the technicians reading those are looking at adequacy of the film. It's almost the way a technician would look at an X-ray and say, yeah, it's readable, nobody moved, you have a clear picture here, but they aren't going to interpret whether there's a break or not. Same thing with the MRI. And for me, the ethical issue is this: these are healthy controls in above minimal risk studies with no benefit to them.
Mhm.
And that's said in the consent, and they're compensated for time. But what's the obligation if they're having something that would be the equivalent of a clinical MRI? And in the cases I'm thinking, they're of the brain because that's what's being studied. Is there a clinical obligation to maximize benefit? And maximizing benefit would say this MRI should mean something.
Mm.
If we can make it mean something. But then who's going to foot the cost for that, right? And is the obligation for the PI to go, in terms of maximizing benefit, to go beyond the minimization of risk at that time? And so I think these are hard issues. I hope we can keep them on the forefront, though, because it might improve, I think, our relationships with our subjects, who actually are participants in research, and without them, we wouldn't get very far. So I keep thinking of that relationship as well as a motivation for perhaps providing a benefit that we can assure we are providing. Right now, we can't. Right now, we can't.
I love. Oh,
yeah.
Go ahead, Linda.
I was just going to say, I know I'm not going to read our consent glossary language out loud, but really I agree with Madeline on this. It's really a difficult issue, and I think it's not just, it's a cost issue. It's also a liability issue. I mean, in some consent form templates I've seen, they even go so far as to not want to even, like, as I mentioned, return anything to a quote provider or let someone know. They put it on the actual participant to say, well, we think we see something that might be of concerns, but we'll leave it to you to go ahead and discuss this with your doctor. And we have no intention of giving you a copy of this MRI or this certain information. And so it's something that we have to really address as a community in terms of what sort of the expectations are, but it is difficult because there's the cost issue. There is the specificity of the actual MRI, you know, whether or not the person who's reading it, are they qualified? What happens if, even if you have an expectation that you return information, what happens if something's misinterpreted? And so you get into all of these difficult issues, the legal, the cost, and then the ethics. So yeah, difficult issues here.
But really important to have the conversation that we're even having here, because I mean, this isn't new. I know from 20 years ago that this was stuff we were discussing, and I think we have made some progress, and we will continue to take these cases as they come up one by one, because again, the other issue is there isn't really a one size fits all for coming up with these solutions, right? And so the better we can just articulate what we've done in particular cases in order to move it forward. May not fit every situation, but it does allow there to be some precedent set that we've done it in this way. We've done it in this context. Let's think about a way forward in a different context. And, thinking about what you said, Madeline, about how these participants, I mean, without them, we can't do the research. Alexandra Haddad had a question about, whether you learned anything about patients' reactions after getting their data or questions they asked. I suspect maybe in this case, they didn't even necessarily know. Well, let me just back up. I shouldn't make any assumptions. Did you hear anything from participants in the study around sort of what happened if they were found out they were positive, and like if the investigator had to reach out, if the provider had to reach out to them or anything, or did you not really get to hear about what happened downstream?
I didn't hear anything. I mean, I will say one thing I might have mentioned about the case was some of the individuals were already suspected of having the infection as well. So that was one piece of it, or they had symptoms. Not all necessarily, but that was one piece of the study. Am I correct, Madeline? I think that's what we put in the case study.
That's right.
So that is something that they probably were going to be too surprised necessarily. But if they maybe they already had a COVID test that was done, they were waiting for, and then they had this result that came. When I say result, meaning their provider told them about this unconfirmed finding and were waiting for the clear results, they would have probably had to act more quickly to address the potential infection. So that, again, we didn't hear there was any sort of concerns raised, but I don't know, Madeline, did you hear anything from the I didn't hear it yet.
No, there weren't complaints, and a number of the participants ended up being Yale employees, right? Because it was being done at that point. And the one thing they heard that they wanted to know, because they were working in a hospital, felt like they were frontline. Again, this was so early. Remember, we didn't know what spread it, whether touching groceries would give it to you and so on. And they were worried about their families. Yeah. So I think they saw it as something that was a benefit.
Yeah, really, really great, and great question, because we always want to think about, what could the potential patient participant experience be in that, and and I think this study in particular had such great back-end infrastructure to be doing the non-validated test and also automatically sending to the CLIA validated lab. So it was really almost without the participant really knowing all of the back end stuff that was happening, in order to make sure that they could get the information that would be as helpful as possible for them and their families. So well done in terms of doing that. So one last question that I see in the Q&A here, which could be really interesting, is what if the samples were collected with a waiver of informed consent? Would that ever happen? Are we talking about maybe clinical specimens, discarded specimens? I don't know if Mike wants to give any more context for it, but I'll let Madeline and Linda start kind of.
Sure, hi, everybody. I'm Mike Link from the University of Cincinnati.
Hi, Mike.
We do have a protocol where they are prospectively collecting blood samples, a small amount, without informed consent. And we struggled with what to do if they had any clinically significant findings. They said they were just doing research testing on those, and there would be no clinical significance to the samples. So we opted out with saying don't return anything, but I'd love to hear your thoughts.
Was it leftover? In other words, they were getting a clinical draw. There was leftover blood.
They're doing a blood draw. We could go down that path. That could be a whole nother seminar, webinar. But yeah, we did approve it. It's an expedited study. It's being done out in the field. So it is being collected for research.
And probably a waiver of documented consent.
Yes.
Not, but so they know you're drawing blood for research.
Maybe I shouldn't have got on here. No, they don't. It's a complete waiver of informed consent.
Okay, I'm not going to speak for all my.
No, I don't want to get into that.
I just think I want to
say it was a clinical specimen. That's fine.
If it were leftover blood, we see a lot of that, and it's often not human subjects research, because they'll take the leftover blood with no identifiers. Sometimes they'll have gender on it if gender is relevant. But they, and in that case, then it's not human subjects research, if truly anonymized sample at that point. I don't know that we would have ever waived something where you're actually, even if it's a finger prick, it's still invasive in a way, right? You're sticking them without informed consent to get it done. So I don't know, but we do have field work going on And in that case, if they're not collecting enough information to contact them again, there is nothing going back.
Mhm.
And that can be. We have drop-in clinics that have started, and they just ask if you'd like to give a sample. We're sampling for this. They were sampling for one urban kind of a virus that's related to a rat population and so on. And they were just trying to sample anyone who came into the clinic. They just want to know, it's an epidemiological question. And it turned out not to be human subjects research, but only for the blood stuff, they had to get consent because they were taking blood spots.
Mhm. And I mean, I think I would say I am no IRB expert, but I have worked in the IRB before. But if we're not getting informed consent and people don't know they're in research, it does open a whole lot of questions to start returning results to people if they didn't even know they were in a study to begin with necessarily. So interesting question, Mike. Thanks for bringing it up and for giving us a chance to kind of mull it over a little bit. And thanks to everyone who provided questions and to this really attentive group of participants, audience here. It's really been wonderful to have everybody listening in and engaged in this conversation. And Linda and Madeline, thank you so much for taking time out of your hugely busy schedules to spend a little time with the MRCT Center and our wonderful collaborators and colleagues who were interested in learning a little bit more about your experience in this wild world of returning individual results and data.
And I want to apologize for a bit of a knee-jerk response to the last question, because there's probably a very good reason why that was done. And when I learned more, I've often paid the price for a knee-jerk off-the-cuff response. So I apologize.
Oh, Madeline, you and me both. You and me both. We've got something in common there. But passionate people sometimes don't have a poker face. So, well, I wish everyone a wonderful rest of the day. I see that there were a couple of things in the chat here. So I just want to quickly read through. There are a few thank yous, so wonderful for that. And Annette, you made a note here. We frequently hear from vocal patients participating in our research that they would like to be considered partners rather than subjects in that research. And that would mean they have an opportunity to hear about their non-validated research findings. I often wonder whether this is where we are heading as a society. It is complex and difficult, but yes, ... The conversation continues, and we will continue to do this work. And I think we are moving into this sort of information democratization, right? So with all of its warts and everything that comes with it. So thank you again. And if you have any questions or anything that comes up, feel free to email me. I can pass it along to Linda and Madeline. And I'm just really grateful to this entire community of folks that really care about making sure results get back into the hands of participants. So stay tuned, come to the September session if you'd like. Megan Frone will be talking about genetics and genetic testing and return of results in that. And that will be just as prickly and as, many issues to discuss as this and the one that we had before on figuring out a nice solution in industry. So yes, I will break. I will let you all go on with the rest of your days. And thanks so much and hope to see you in September.
Thank you, everyone.
Thank you.
Thank you.